Hi, this is John Kanellopoulos from our center here in Athens, Greece, the LaserVision Ambulatory Surgery Center and Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. Very, very interesting case. This is classic Salzmann's keratopathy. We can see the white hyaline patches, if you may, in the peripheral cornea, superiorly on the side. Nice view here with anterior segment OCT. We can see that there's a delineating line separating from the stroma, although sometimes we feel that these are within the stroma when examined with slit lamp. Significant cataract in the 74-year-old lady, and the field cell count nevertheless very good. Some polymagnetism seen here. We're addressing the left eye. As you can see, a T9 lens, not available in the US, available in Europe, at the against the rule axis based on the keratometric data. My 135-degree incision, 2.75 and 1mm paracentesis. Viscode in the AC, methocellulose on the surface, a continuous curvilinear capsulorhexis. Things are speed up here ×4. And although the visibility is not very good, it's clear enough for me not to have to use a blue or any other dye. Hydrodissection, hydrodelineation, mobilize the lens, and we're going in and we're realizing, as we saw in the IOL master previously, this is a significant cataract. We're using divide and conquer technique. Nucleus is out, going in carefully to remove the cortex. Of course, the take-home message here is not the cataract procedure of this lady. I just wanted to share with you the challenging part of the procedure with these opacities in the cornea and obviously the significant external disease that this poses to the patient. It's kind of underlined by the conjunctival hyperemia, which is there all the time. Remember, we have put neosynephrine and it should have gone away during the procedure. So we're using our toric clarion lens, T9, almost against the rule axis, nothing really significant till now, until we make the decision after the completion of this very good procedure, going under the lens to move viscoelastic over the lens. So a uneventful cataract procedure, and now we're taking the decision, of course, in communication with the patient, that we're going to remove these nodules. And this is really something you have to do very carefully. We're using a blunt, a pre-used crescent blade, because the difficulty here is that you can find yourself within the cornea stroma. You have to find the edge, and this is a little tricky. So you can see here, this is ×4 in speed. I'm teasing until I can grasp the edge, and once you grasp the edge, you just pull it off. It just sticks away, the whole thing in one piece. It's really remarkable. And this is the take-home message from this procedure. I'm continuing with my crescent. Again, this is a crescent. The only occasion that we re-sterilize crescent blades, because I want it to be blunt. You can very easily go through stroma and do a superficial keratectomy along with removing the Salzmann nodules here. This one was partially pterygium as well. So cutting in the edge, making a fresh start. Everything looks great, but of course we have histology images here that we will see in a few seconds, and the confirmation. And it's very interesting to see under our pathologist microscope that there's epithelium growth over this hyaline material, and we know that this is expressed in long-term external disease, significant blepharitis, dry eye, again here with H&A dye, the pink hyaline material, the epithelium on top. This is part of the pterygium that we had removed on the edge, a tiny pterygium, and the lens is uneventful. The problem is the patient is now a -6 and has 4 diopters of astigmatism. Why is that? Because now that we cleared the surface, we're dealing with a different cornea, and this is the same cornea that we saw before, impeccable in thickness. Everything's gone. The difference before and after with our anterior segment OCT, the OptiView Avanti angio view, and here on the pentacam, the prior and after. And you see how drastically Salzmann's had contributed to the astigmatism before, which is not present now. And the keratometry has changed, has steepened significantly. So now we have a different lens power that we're calculating, and we have to go. Our success has created a big problem. We have a perfect cornea, as we can see here. You can also see that the hyperemia conjunctiva has reversed. I'm trying to track the old incision. I can find it with my Sinskey hook. A little bit more difficult in my paracentesis. It's obviously smaller. It's 1 millimeter. And you guessed it, I will go in and remove the original lens and go in with a replacement lens with a new um, cornea reality. We are just 3 weeks out from procedure, so I think it's the optimal time interval to come in before a synechia are formed with our lens in the capsular bag. Teasing in here with my paracentesis. I will slightly enlarge the incision from 2.7 to 3 millimeters. Very easy to go in with my Sinskey and pull out the haptics into the anterior chamber. Remember, I have viscoat in the anterior chamber, and I will place some viscoat under the lens. I will grasp the lens and bisect it with my IOL scissors, 2 pieces, and then carefully go in and pull out each hemi-meridian of the original IOL. And again, there was nothing wrong with the original procedure. It's just that these Salzmann nodules had created a cornea um, functional to a completely different level, much flatter and with significant astigmatism. So the capsule bag is naive. Currently, a different lens, much lower power, much less astigmatism, and more importantly, a different axis. We're with the rule here. We're against the rule before. So our IOL in place, nothing really eventful here. Besides postoperative, a very happy patient. We're 20/20 plus the first postoperative day. And here, the take-home message, number one, how we remove Salzmann nodules. Number two, how they can significantly contribute into alternating our keratometric measurements, regardless if they're in the periphery. Remember, most cataract surgeons pay only attention to the central cornea, but we can see here how the peripheral scarring and amorphous material deposition with Salzmann alters the behavior of the cornea, hydrating the wound. This is the patient, the first postoperative day, 20/20 plus uncorrected visual acuity, and I like the cornea that I'm seeing pristine without any Salzmann nodules. Perfect reflection for material film, besides her being very early postoperative. John Kanellopoulos, hope you found this interesting. Signing off.